Precious Father God, in the name of Jesus, we're grateful, Lord, for an opportunity to be alive today. We thank you, Lord, for giving us such a time like this, Lord. Lord, as we congregate, Lord, even as presenters, O God of glory, for this 5th International Conference, Father, we ask for your presence, that Lord God, may you go before us even as we begin this morning, in the name of the Father, the Son, and the Holy Spirit. We pray. Amen.
Thank you. Dr. Ndombera.
Oh, yeah, I'm ready.
Dr. Ndombera.
Yes, can you hear me?
Can you hear us?
Yes, I can hear you loud and clear.
As we wait for Dr. Ndombera to log in, we could have presentations. I've seen Medihill with us. Is Medihill team in the house?
Hello, I'm logged in.
From Eldoret Hospital, are you in the house? And also Fountain Healthcare. If the representative is here, please step to the podium and make your remarks.
Dr. Ndombera is logged in.
Dr. Ndombera?
Yes, I'm logged in. Can you hear me?
Yes, we can hear you loud and clear. Session chair, come and welcome Dr. Ndombera so that he can deliver his keynote address.
So, honorable delegates, allow me to introduce our keynote speaker, Dr. Fidelis Ndombera. Dr. Fidelis Ndombera is a research scientist at Covance Laboratories in the US, which is a global drug development company. He obtained his PhD in chemistry from Wayne State University in the US. Dr. Ndombera leverages his experience in organic and biochemistry in biochemical cancer and COVID-19 research. He has widely published. Dr. Ndombera is a recent collaborative, he has a recent collaborative work with the Kenyan researchers, and he's a member of American Chemical Society, American Society of Clinical Pathologists, and the National Organization of Black Chemists and Chemical Engineers, among others. Dr. Ndombera, you are most welcome. Please, you can now have your time for your keynote address. You are most welcome.
Thank you so much, Dr. Nyongesa and everybody at Kibu University. I'm very delighted to get this opportunity to make a presentation, to my countrymen. Could I allow you guys? Could you allow me to be able to share my screen, please? Once you do so, then I will be gladly proceed. I want to be able to share my screen. Can I be able to share my screen?
Yes, sir. Dr. Ray, go ahead and share with us your screen. Share with us.
Okay, thank you. Just a minute. All right, so I'm going to talk about whether the SDG3 targets are achievable, and we try to see whether we're going to be able to learn some lessons from this COVID-19 pandemic. So I mean, like I said, I'm really glad to be presenting to my countrymen. And again, I mean, east or west, home is actually best, and actually north or south, home is still best, because these are the 4 seasons we go through in the US. And although I know it's attractive to many people, those of us in the US sometimes wish we were back home, and conditions in the US, I know, would be at home. I mean, everybody would be happy. So I did put here my number and my email just in case you need it to be able to connect with me. I know I'll be trying to rush through my presentation, so feel free to link up with me any other time, or whether you have any other questions. And so we are talking about Covance. I work for Covance, is a drug development company, and we do work from the bench to the bench side. Now, a contract research organization in the US, such as Covance, is involved in drug development. And so companies that make drugs contract us to make, to do research for them. And so this is something quite interesting that maybe can be, be done in Africa as well. It's a large company. It's owned by what is known as the Laboratory Corporation of America. It employs more than 50,000 people in 60 countries with an annual revenue of over 200 billion Kenya shillings. Actually, we pride ourselves to be the largest central laboratory network in the world. And it's a great place to work. And so, will the COVID-19 pandemic threaten attainment of SDGs? I know many presentations yesterday alluded to the same, and indeed it is true that we do know that COVID-19 will threaten attainment of SDGs. My focus will be on whether this pandemic is going to, threaten attainment of the health, SDG 3, which focuses on health and well-being. Obviously, we do know that all other, SDGs are going to be affected by the COVID-19 pandemic. It's in public domain. We can see it in our neighborhoods, and so I'm not going to belabor that point. So let's talk about goal 3, to ensure healthy lives and promote well-being for all at all ages. This is the goal 3 that was set, and many, countries agreed and, believe that we can attain this goal by in the next 9 years. We are striving to end epidemics. We are striving to end AIDS, tuberculosis, TB, and malaria, and of course, other communicable diseases. I'm very sure when we were coming up with this goal, we didn't really know whether other communicable diseases will include COVID-19. So at the same time, countries committed themselves to, engage in research and development of vaccines and medicine. This is under SDG 3. The question today we are trying to ask, really, have we gotten the support to do R&D in vaccines and medicines? And no doubt, COVID-19 vaccines is a major issue currently. So let's talk about COVID-19 vaccines. Some people think that, certain countries are going to be able to cover, all the entire population by the end of 2021. And as you can see here, the ones in blue, including the US, Europe, and other countries such as Australia and Southern America, shown here in light blue, are going to be able to cover the entire population by mid-2022. Look at our Africa. I mean, it's from early 2023, it's believed that that's when we're going to be able to, cover the entire population in Africa. Thankfully, as much as we complain in Kenya, Kenya is actually ahead of the pack in African countries. It's among the top 5 countries in COVID-19 vaccinations so far, which is quite encouraging to know that despite the political noise that occurs, from time to time. And so, we do know that at least 90% of the African nations are not going to be able to meet the September target of being able to vaccinate at least 10% of their populations, and that is according to the WHO, and that's a worrying trend indeed. And it made me remember, this satellite image that actually normally refers, that. This satellite image reminds me of how they refer to the African continent as a dark continent. Actually, this is a satellite image of lights in the night. You can see the US here is brightly lit, Europe is brightly lit, and now Africa, just like they say, the dark continent. Literally, it is a dark continent. But there is light at the end of the tunnel, and we do need to believe that yes, indeed, there is light at the end of the tunnel. And so, so obviously we're talking about SDG 3, and if we consider the level of vaccinations in Africa, it's really worrying indeed. And we do know that, yes, SDG 3 is under threat. There's a lot of evidence. I went looking around for evidence to really find out, is it really true that we're not going to be able to attain this SDG 3? Yes, of course, we know that. We can see that from our environments. But then empirically, many studies, such as those ones in Europe, as shown here, other studies I went and checked in the Middle East, other people believe as well, we are not going to be able to meet these goals. If you go to South America, it's exactly the same thing. So for sure, there is tremendous evidence to suggest that we are not going to be able to attain SDG 3. The question is, what are we going to do about it in the post-COVID-19 era? What are we going to do? And I believe that is the theme of this conference. Certain publications are a bit more positive, and I like to look at it that way. For example, this one that talks about the opportunities available in collaborative research, in trying to be able to attain SDGs. And I think that is the way to go. How can we be able to have this collaborative kind of research that indeed has been brought about by concerted efforts of many countries in trying to find vaccines and medicines for COVID-19. But ladies and gentlemen, coronaviruses are endemic. These viruses are here. They are with us. They've been with us for quite a while. We do know they can lead to an epidemic. We now know they can lead to a pandemic. And I mean, they cause many diseases. We do have the MHV, and this is a virus that affects mice. And actually, we do also know that almost 30% of respiratory infections every year are caused by coronaviruses, including the ones shown here. And so it is actually true, and it's very well known that all epidemic coronaviruses in humans are from bats. And often we also do have intermediate hosts, such as what we call, the pangolin. And it's widely thought that the COVID-19, originated from bats and then went into the pangolins. The Chinese do feed on pangolins, and then, of course, from the pangolins, it went into humans. And it is believed that, COVID-19, the first case must have been around November or December 2019. But then again, fellow Kenyans, I can tell you for sure that coronaviruses are with us. Look at this publication. This is a publication that was, published in December 2019, well before the issue of COVID-19 came about, and that suggests that actually we have evidence of coronaviruses that are detected in bats, in Rwanda. So they are here. And if you think they are not, they're actually in Kenya. They're actually in Bungoma as well. Look at this publication that was published in 2017 by a team of researchers from CDC from the US. This is a research that was done in Kenya, and they collected, species of mice all the way from the coast, all the way to the Western province, including areas around Kibabi. And it's really something to worry about now that we know that it can cause a pandemic. And so that is the truth. Now, this study was done between 2007 and 2010, and look at what the authors wrote. They did write that our screening of bat samples collected in Kenya from 2007 to 2010 detected RNA from several novel coronaviruses. So these are novel coronaviruses. More significantly, they identified sequences that were closely related to these, human coronaviruses, suggesting that these two viruses are originated from bats. So post-COVID-19, we need surveillance to make sure that we take care of emerging, strains of coronaviruses that can indeed cause a pandemic. There are actually a lot of research that has been done. Professor Bulimo is a researcher, at JKU and Emory, and he had also published a paper, molecular characterization of human coronaviruses, and the study was done between 2009 and 2012. Actually, earlier on, a team of CDC researchers, also were able to characterize 7 distinct bad coronaviruses in Kenya. Not to mention another one also done a little bit earlier in 2009, following the outbreak of SARS, which also showed that actually we do have a lot of coronaviruses in Kenya. And so what is interesting is that, Bulimo and others, they actually did note that sustained respiratory virus surveillance is necessary to monitor the introduction of these dangerous species So we do have a team of experts in Kenya who do know about coronaviruses, including Professor Bulimo, Dr. Lutomi at Kemri, and many others who do know about this. So going forward, post-COVID-19, we need to embark on a lot of surveillance. And one thing that came to my mind, which can be a subject of research, by a team such as from universities such as Kibu, is to consider, going on about this research and indeed looking at wild birds that are a delicacy in Western Kenya and others. For example, I know the Isindu bird. I used to love it. Who knows? These wild, animals, these wild birds, chicken in Western province and indeed in many parts of Africa are domesticated. They are not inspected, and who knows whether they have, such dangerous viruses. Well, that's Kenya. Let's talk about the US now. The COVID-19 mortality in the US has been worrying. As of yesterday, they reported up to 600,000 cases of COVID-19 deaths since this COVID-19 outbreak. So 600,000 people in America have died of COVID-19. But I wanted to show here the age profile of those who are dying from the disease. If you do not know, 80% of the deaths that have occurred of COVID-19 in the US are of those people aged 65 and above. In fact, 95% of the deaths are from people who are aged 50 years and above. I'm showing this because it might be interesting to learn that the age structure profiles of the people in Africa and in Kenya are indeed different. We only have about 2 to 3% of the Kenyan and African population aged about 65 and above. The question is whether our young population in Africa is actually protecting us from, these mortalities that are coming about from COVID-19. So if you look at only one factor, age, there's a great likelihood that the young population, for once, has been a good thing for Africa, since the low death cases, could be attributed to one factor and others. And what is surprising is some publications out there, are interesting. Like this one says, why is the number of COVID-19 cases lower than expected? Interestingly, people want to think that it should be high. Africa is always a bad case, but I thank God that that's not the case. And so if you contrast that with, the age structure profile of, the US population, you realize there's almost a very good distribution, 3%, or 6% on all age sets, all the way to almost age 60 and 65. But then again, meaning we don't have a very huge young population. In fact, 20% of the population in the US are aged more than 65 and above, and probably that accounts for the high, death cases in the US. So, switching on to something else here, let's consider whether qPCR tests that are now a gold standard, in determination of in determining whether somebody is positive or negative. Now, in one study that was done early on during this pandemic, actually from 3 patients from Wuhan, China, suggests that COVID-19, tests are not really that, reliable, so to speak. So if you take case 1, where the onset of COVID was detected and, PCR tests were carried out on the first day, they showed this a positive test. But on the 4th day, the test was negative. If you go along this, across 3 or 4 weeks, it appears that certain days, the same patient who is still having symptoms of COVID-19 is testing negative. Other days, this patient tests positive, and then negative, and then negative, and then positive. And so even if you get a negative, COVID-19 test, who knows, you could still be having COVID. And so That is even compared with the patient, another patient, case 2, who is a son to case 1, also showing a similar trend in the first, 2 to 3 weeks. The patient was testing, positive. In certain days, the patient tests negative. These are from nasal swabs. So however much you try, it's coming out negative. After another day, it's positive. So really, qPCR tests are not really that, foolproof. But then again, it's the gold standard right now, the world over, because of the, the ease in which you can do this test. And the similar trend was seen in patient 3. We was a patient who had traveled from Singapore to Wuhan, from Wuhan to Singapore. Now, if you look at the X-ray images of these 3 patients, patient 2 and 3, they seem to appear, almost the same, whereas you can see certain infiltrates in the lungs of case 1. And so, traditional methods of looking at, whether the lungs have been affected do not really normally, discriminate between the ones who are sick or not, because 2 and 3 are sick, but you can't see that from the X-ray. Neither can you rely on the COVID-19 PCR test, suggesting therefore there is a need to include other kinds of tests. We do have other tests. For example, we do have another emerging technology among many other technologies known as the nanostring technology. Now, I'm aware that you may not be chemistry savvy, and so I'm not going to be trying to, challenge your chemistry grade by trying to explain a lot of chemistry behind this new kind of technology. But in a nutshell, we are able to target, many. We are able to target up to 800 targets, from an RNA sample, and so. This method here is a little bit different from qPCR. We are not trying to amplify the RNA. We are simply getting, some blood tissue or a lung tissue, and we extract the RNA, and then from that RNA, we are able to profile, genes that are being expressed in a patient, and trying to see certain differences, in gene expression in those patients. And so, simply put, nanostring is simply very simple, in a very simple way. You extract, RNA from a tissue or blood sample. This is just a simple, RNA target. And so what you are doing is you have what we call a capture probe and a reporter probe. So this is another, sequence of, nucleotides that we're gonna attach to the RNA. Now, this target, like I said, has been, it has come from the patient. And so these two, the capture probe and reporter probe, will hybridize or will combine with the target. And because we have these reporters, you can be able to actually count the number of, genes in that sample and be able to compare with healthy controls. And so this technology is automated. It takes about only 1 day. But the benefits of it is that you're able to see the gene expression levels of many genes ago, up to 800 targets. When you do the qPCR test, you're actually targeting only one particular target at a time. And so the difference here is that you're targeting 800 versus only one in a qPCR test. So this one is more comprehensive. Obviously, it's out of reach for many people, but it's good to know as an academician that we do have better technologies that are solving problems beyond what is common knowledge to many people. I'm not going to bore you a lot with this picture, but I want to just be able to illustrate a little bit about what you are seeing here. So in this study, of the 3 patients I talked about earlier, case 1, 2, and 3, and healthy controls, what you are looking at is what is called a heat map. A heat map simply profiles or shows levels of gene expression. So what you are looking at is that when you see this red, image here, it simply shows the levels of gene expression, and each line is a gene. So going downwards, every column is a patient. So these are 10 patients. So every column is a patient, and every line is representing a gene. And so when you see red, it means overexpression. When you see blue, it's underexpression. All what you need to see in this picture is this: that look at the gene expression profiles of the healthy controls versus the COVID-19 patients. So even just looking at this point here, this looks red, this looks blue, meaning that many genes are being underexpressed in a COVID-19 patient compared to a healthy control. Now, indeed, the changes are taking place every day. So this is day 4, day 5, day 6, day 7 going forward. And so these gene expression changes keep on changing as the patient, progresses in the disease. And at the end of it all is a total collapse over, the metabolic system of the patient, similar to HIV, and unfortunately the patient has to pass away. And so nanostring technology is revealing the changes that are occurring at a molecular level in the patient. And so the only way forward is to be able to find ways to target these genes that are having, being turned down or being turned up, so to speak. And so going forward, post-COVID-19 era, what I'm saying is schools such as, Kibu, researchers at Cambridge, researchers all over the world have to find ways to look deeper into the effect of these viruses in human beings, now that we already know that coronaviruses are with us, including our very own neighborhoods right there in Bungoma. So, ladies and gentlemen, how do we mitigate this, the post-COVID-19 impact? Of course, I've already said vaccines is one way. And yesterday it became very clear that, vaccines is a major way by which we can, combat, COVID-19. For those who do not know, we actually have 19 vaccine candidates according to the World Health Organization. If you go to their website, you'll be able to realize we have 19 vaccines that are out there, including, the ones that are not yet in the market. We do know Pfizer, Moderna, AstraZeneca. We have so many others coming in the pipeline, Novavax, we have Sputnik from Russia, and many others. Actually, like I said, we have 19 vaccines that are going to target COVID-19. Secondly, surveillance of coronaviruses in birds, in animals, and in humans cannot be ignored going forward, because we know that diseases such as COVID-19 can strike at any minute. Thirdly, collaborative research cannot be ignored in drug and vaccine development. I know there is this common notion that, do we have funds to do this research? But then again, people always argue that there are so many, funding, bodies, and those funds go unused, utilized every year. And some of these funds, target developing countries. And sometimes it pains me to learn that the funds go underutilized, yet our scholars in Africa keep on complaining of funding. And so that is a conversation that we have to, keep making, that we can do research if we search for these scholarships. Fourthly, public education, of course, is key. We do need to understand that, of course, there's a danger in dealing with, organisms out there, including domesticated animals, being in close proximity with them without, being sure whether they have a viruses is going to be key. Not to mention that, there are ways to reduce the impact, masks and so on and so forth. And I know the world over COVID-19 is actually a political question right now, including in the US, in Africa, and all over. We do know that even in the US, there are people who have refused to take vaccines, including medical personnel, for political reasons. And so public education cannot be ignored. And when we talk about education, universities are fundamental in being able to further, provide the necessary tools to make sure that the public is informed. And indeed, such a conference is, very commendable in trying to pass on the information. And of course, lastly, no doubt there's overwhelming evidence that we are not going to be able to achieve the SDG goals because of the disruptions that have already been alluded to by many speakers in this conference. Thank you, ladies and gentlemen.
We've learned a lot. Honorable delegates, you can attest to it that Dr. Ndombera is a researcher who is a real-time researcher. I'm amazed, especially his first-hand information, both globally, nationally, and even locally. He can talk about Kibabi as if he lives in Kibabi. We are quite privileged to have listened to your presentation. You started by giving us a picture of the African nations and the possibility of missing out on the September target of vaccinating at least 10% of its population. However, you told us that there are opportunities that can enable African nations to attain their sustainable development goals. And then we have also learned that coronaviruses cause many diseases across the animal kingdom. Many of us have been thinking that this is a human virus, but now we know that it actually affects all the human and animal kingdom, especially the two types that could be even within our locality, that is the NL63 and 229E, which are the type of bad coronavirus. But apart from that, you have also told us that there is need for surveillance at all times if we want to survive. You painted a picture of the American status and the Kenyan status and the African status. Yes, there is hope in Africa, there is hope in the country, Kenya, but we need a lot of surveillance. Then you have summarized by giving us ways of mitigating the post-coronavirus impact. One, that there is need for vaccination, wide vaccination. Then there is need for surveillance, not only among human beings, but among birds, domesticated animals, among others. Then you are calling upon collaborative research, including drug and vaccine development, and then public education and awareness, among other measures to mitigate the coronavirus. So we are so privileged to have had an opportunity to engage with you, to listen to you. We are going to have a plenary session. I know many people have questions. They have sent them on the chat. Please just get them. We are going to have a session where you will address them. At this point in time, allow me to invite Fountain Healthcare for their presentation. And then thereafter, we shall have a plenary session where we'll ask our questions and give our comments. Medihill, are they around? Immediately after Fountain Healthcare. Okay. So Fountain Healthcare are ready, please. You're most welcome.
Thank you.
You have your 10 minutes.
Thank you. So, ladies and gentlemen, good morning. Good morning.
Good morning.
I am Dr. Akoto Anthony, Chief Medical Officer, Fountain Healthcare Limited, a partner of Kibabi University, and we feel very privileged to be here today. together with me, I have a team from Fountain Healthcare. I'll just request them to stand so that the audience can recognize them. Just stand, be on your feet. Dr. Molly Akim, the lady on the far left. She's our resident medical officer. It's good that you know them because most of them you interact with them at the hospital. So, Dr. Molly Akim, she's our resident medical officer at our Fountain Healthcare Bungoma. Most of the time, she's the one who is taking care of you when you come there. And for us, we've made at the hospital a policy that the services we offer, we at least the junior most is the medical officer going upwards just to maintain our standards of care. Next is my senior colleague, Dr. Caleb Wanambisi Wata. He is the chairman of council for the doctors practicing at Fountain Healthcare Bungoma. And on my right is Miss Evelyn Nyongesa, and she is our hospital manager for the unit in Bungoma. Thank you. So, first and foremost, I wish to congratulate Kibu University for this momentous occasion where we are hosting this 5th international conference, and this in a way puts the university in the limelight, puts in the global map, and all the scholars across board are able to come together and share experiences across various fields. COVID-19 has been a pandemic of magnanimous proportions that has taken all of us by surprise, including even those in the medical profession. I don't think we were ready, and I don't think pandemics sometimes get you when you are ready. And you know, we are all learning through it, from researchers, scientists, scholars, educationists, on evaluating how this has affected us. Shortly, I'll just wish to maybe share with you what we are doing and also what our experience has been, and perhaps our little contribution in management of this pandemic. You just put for me on slide, full slide. Don't mind. Slide show. So, as an organization, we were established in 2012 under a group called Fortune 500 Health Group. And this is a group of doctors who came together across the country. And what we looked forward was that we would wish to offer multidisciplinary, interdisciplinary approach to patient care in what you would call a supermarket of doctors. So doctors across the country, currently we are about 360 across the whole republic who came together to form this particular group. And this was occasioned by a problem that was there in 2012. If most of you can remember, there was a doctor strike in 2012. And out of that strike, we started asking ourselves as doctors, is there something we can do in our space rather than being there and complaining every now and then, maybe of how the government is treating the Department of Health in this country. And that is what gave birth to Fountain Healthcare. Next. So our mission and what I would just wish to dwell on is we believe in holistic approach to offering healthcare services, whereby when you come to us and when we interact with you, we're able to look at the physical aspect, we're able to look at the emotional aspect, we're also able to look at all the other attributes that contribute to the general well-being of any person who comes to seek care. Because most of the time, and most of the scholars here will agree with me, you will want to focus more on the clinical aspects. And yet there are many other things outside the clinical aspects that could be contributing to the health status of an individual. So that holistic approach to us, we believe is key is an approach that is slowly taking shape, and we believe we can push these conversations to the higher levels of care, even in the public sector. Next. Next. So among the services that we are able to offer, general and specialist consultations, internal medicine, pediatrics, reproductive health, surgical, laboratory, among all these that we are offering. Currently, we have 4 units in this republic. One is the Fountain Healthcare Bungoma, where it's a 16-bed capacity facility. We have a subspecialist clinic in Eldoret and Nandi Road, just after St. Luke's. We also have a 36-bed facility in Eldoret, a level 4. And recently, we have opened another one in Nairobi at Kahawa Sukari, which is a medical center, a level 3. Next. Among the partners, we are proud to have Kibu University on board for the last about 10-11 months. And we appreciate your support as an institution because we are able to participate in taking care of the health of our people who are with us in this particular community. Next. So on our response, I know a lot of discussions have been on this, and you must have heard a lot about this COVID-19 up to this point where we reached. And you know, what we have observed at our facility is that the old age has been a key factor, especially in our Kenyan setup, those above 55 years. We've had them getting seriously ill and they require hospitalization when they come to our place. And then those with cardiovascular diseases, the heart diseases, also we've admitted several of them. Those with diabetes, chronic respiratory diseases like asthma. And then we have also admitted quite some number of cancer and those with hypertension, among others. Why am I saying this? These are diseases that afflict members of our population. And perhaps there are those of you here who could be interested as researchers, because this is data being generated and it's quite new data. That this is what, as hospitals, we are observing and is what is in our files. So perhaps in future, and I'm happy, Kibu University is starting School of Nursing, if I'm not wrong, this academic year. And you see, this will be some of those you know, information that will be key, even as we try as much as possible to make that curriculum very interactive. And by the time the students are coming out, they're able to absorb and utilize this data in patient care. So on prevention, I think this is just what we've been trying at the facility and what we are advocating. When you come there, we have a small chat. Dr. Moli Akim always will keep on talking about several things. But again, most important is that people who smoke, we have again seen very poor outcomes, especially when they slide into high dependence units and the ICU situations. So we've advised that, again, it's an observation we've made, that for those who are smoking and you're sliding into, you're getting a serious disease that requires hospitalization, most of them, about 30–40%, we see we don't get a good chance to get full recovery. Next. So among the signs and symptoms, I think these have been evolving. You realize initially, we will take temperature, you know, we will ask about cough, among other things. But of late, if you are careful, you realize you're just okay. But when you go to take the test, you find you're positive. So it's a disease that has been rapidly evolving. And I think Prof tried very hard to give us the scientific side of it and how it has been working in terms of studying those particular changes and what has been happening among the trends in the disease progression. And we believe there will be much more data that will be generated even as we continue learning more about this disease. Next. Among the the less common symptoms, which I will say in the last few weeks, especially with the face of the pandemic in Kisumu currently, we are observing that what we call conjunctivitis, you know, the irritation of the eye and the reddening, and sometimes even the pupil turning a little bit of blue, is what we are observing of late, especially with the Indian variant that is coming in. So it's quite some new data that is being observed and is being generated. And my hope is that, you know, as an institution, we can also act as custodians of this data going forward, even with the institutions that we are partnering with. I'm seeing hospitals here like MedHill, who are our colleagues, Eldoret Hospital, Fountain Healthcare, among others. So I believe we should be able to, even if we are not doing anything with this data, but we're able to collect this data, and perhaps somebody might have some interest to see why there has been this progression and change of even these signs and symptoms or appearing across different variants. On the vaccine, currently in the country, we've got AstraZeneca vaccine that is available, that most of you, if you've been inoculated, perhaps you must have received that. At the beginning, there was the Sputnik vaccine also, which a few people in the country also were able to get this particular vaccine. And it's important to know that, again, the guidelines have been revised from time to time, that between the doses now we are doing between 8 to 12 weeks. And what we recommend is that, of course, there is a lot of politics around vaccines. But for us as medics, we encourage that it's important that if you have an opportunity, having that vaccine is better than having none. For patients, especially again in Nairobi and Kisumu, where we've been able to collect a little bit of data, we've observed keenly that those who had received the first dose of this AstraZeneca vaccine, especially after 2 weeks, their outcome in terms of when they get sick is much, much better compared to previously, when we had these particular patients not being able, or who had not previously had the vaccine. So what we are seeing is that the vaccine, it is not preventing people from getting sick. But when you get sick, you are not going into ICU. ICU cases have reduced. High dependence units cases have also reduced, even amongst the old persons. Next. So just to let you know that you know, we give this vaccine at the deltoid muscle, just around the shoulder is where the deltoid is, at that location, and about 2 weeks, about 8 to 12 weeks between is when we are giving the first dose. Johnson's and Pfizer that are offering a bit higher protection between 90 to 96%, but we have not received those in the country yet. So I wish to say asante sana and congratulations to Kibu University for keeping this particular culture for the 5th year in succession. And we will be here to partner with you and ensure that even in the upcoming conferences, we are able to participate even in a better way or much more with with this institution. I want to say asante sana and God bless you and thank you for the opportunity that you've given us to present. God bless.
Let us appreciate Fountain Healthcare once more. Yeah, we don't take it for granted that you stood with us. We really appreciate your support and the partnership and the enlightenment that you've done. That is one way of mitigating the virus, sensitizing and educating the public. At this point in moment, allow me to now open the floor for plenary discussion. Sure, the other groups are not yet in. Medihill are not around, neither the hospital. So let me open the floor for questions, for compliments. I know Dr. Ndombera has received a number and want to respond to them. We have Professor Barak Onyo. Please. Dr. Ndombera,
Yes, I'm online.
please, maybe that question is directed at you. So I
Yeah.
hope you're.
Yeah, I
I
can
hope
see several.
you're ready, Dr. Ndombera, if you can hear me.
Yes, I'm ready. Can you hear me? I'm very much ready, and I can see several questions. You
Dr.
know,
Ndombera,
on
if you
the
can
chat.
assure me that we are together.
Yes, can you hear me? Hello?
We can hear
Maybe it's unmuted.
you.
Can you hear me?
The technical team confirm that we have muted him.
Hello?
Those online can hear you.
So the compliments and questions.
He can hear you, Dr. Ndombera.
directed at the two
Oh, I see. Thank you.
presentations.
Thank you. Okay. So do you want me to respond to the questions on the chat?
Yes, I just wanted to confirm that you are listening to us because
Oh,
we
yeah.
have questions on the floor.
I'm very much awake, although it is 2:42 a.m. here, but I'm very much awake.
Ole. Thank you. I think we are now set to go. Professor Barafobonyo, you have a question?
Yes.
I have a few questions for Dr. Ndombera.
Yeah, go ahead.
And I also have a question for the medial. Oh, Fountain. Dr. Ndombera, you indicated that PCR and even X-ray tests are not absolute.
Yes.
Implying that the test that we have currently is not capable of giving us a correct positivity or negativity. And you're suggesting that nanostring would do that. I don't know. The implication is that all these tests that we have been doing is confusing us. I hope you will
I will respond. Yeah,
tell us more about that.
Yeah.
And then in your nanostring test or what has been done, it is an indication of expression or non-expression of genes. And the question is, are there specific genes that have been identified to be identified and confirmed to be turned off by COVID-19 and turned on by COVID-19? Finally, I saw that your company, Covan, is doing a lot of work in the US in terms of clinical trials and even drug testing. At Kibabi University, we have personnel that are capable of performing, of helping or working with companies, especially in terms of clinical trials. Is it possible? How is it possible for Kibabi University to collaborate with Covan? I'll then go to a question to Fountain Healthcare. I think Tari said that people who get vaccinations can still get sick, but you get better response. I don't know how you measure better response. Is it by looking at the amount of antibody produced or by symptoms? How do you get the better response? What is your measure for the elicitation of a better immune response? The other thing I would like also, just the same as what I've requested Dr. Daktari, is that I know you have experience and you are receiving a lot of patients with COVID-19, and you are taking them through processes, and you have data, but maybe this data is not getting published. And us as Kibabi University would like to work with your team to follow up the data you are getting and analyze them and get them published. And I would like to know what is the process, what can we do to work with you so that we get this data published. Thank you.
I'll go ahead and try and respond if you allow me.
Maybe you could check some 2-3 other questions, then you respond, Dr. Dobera.
Much obliged. Okay, that works with me as well.
Very quickly, I want to compliment you for a very incisive presentation.
Thank you.
My name is Brian Singoro.
Yeah, Dr. Sigoro.
Now, from your presentation and what we've learned from the press is that the US has the best Medicare in the world.
Yes.
Africa has nearly the worst Medicare in the world. COVID-19 has pronounced itself more loudly in the US.
Yeah.
More quietly in Africa, and specifically in Kenya. What is your take on this? Then second question is to my friends from Fountain Healthcare. I'm really very pleased to meet a young team of doctors. I feel so happy and so proud. Now, Dr. Wata and team, what is the uptake of the COVID-19 vaccine among the medical people, among the doctors, among the nurses, clinical officers, and so on? Because quietly, we're getting reflections. It's as if a number of them have not gone for them, and they're quite advising other people not to go for them. It is an allegation, it's not yet proven. What is your take on that? Thank you. Yeah.
Yeah, we have one more question, or several. Five, maybe you can respond to those ones, and then I will go from the floor.
Okay, so yeah, I'll try to respond to some of those questions. And I think from the very outset, I must tell you that maybe the responses are not going to be very conclusive. You can always reach out to me later on. This is my responses on one, PCR tests. The PCR tests are actually working. What I did say was that we have to be aware of the limitations of PCR because you may actually get a positive test and a negative test the following day, and a positive test the third day. And so what I was trying to say is that we cannot rely on only one technique to be able to say whether we are positive or negative. We must understand that we have serious limitations of PCR as well. And so that's what I meant. And again, a PCR only gives you a positive or negative test. It doesn't quantify the amount of virus in your body. And so the severity of the disease is not really tapped by PCR. So you are two patients, you go to the hospital, they tell you you are positive, and then the other one is also positive. But the differences between them is left to the doctor to determine the clinical.
Dr. Dobera?
Yes.
Hello, Dr. Dobera.
Yes.
We had lost you. We had lost you, so we plead with you to repeat the answer kindly.
Oh, sorry. I mean, okay. So,
All right.
So I was saying that the PCR tests are working. They are good. They give you a positive and negative test. Yes, but again, we have limitations. It is very limited in the sense that it does not give you the quantity of virus. The way they are designed to give you positive or negative. And so because they do not quantify the virus, then we do not know the severity of the disease. The differences between two patients is not known. And that's why we need alternative methods that can work. Because for certain hospitals, for example, the X-ray, when we see that there's no difference between two patients, what do you do? And so that's what I meant. So PCR tests are okay, but they have limitations. Number two, on genes that are turned on and off, yes, there are so many genes already identified that are turned on or off in COVID-19 patients. Some of the most characterized are the ones that cause what we call inflammation. You know, the lungs swelling with mucus and all that. You know, it's because of a collapse of certain genes in the body. So those genes are already, and if you just Google, you're going to be able to find, just by Googling, and you'll be able to find a lot of information about genes that are turned on and off. Number three, on collaboration. On collaboration, yes, you know, what COVID-19 has taught the world is that, you know, no country is immune to, you know, a pandemic. No country is immune to a viral disease. And indeed, that's why, you know, many countries such as China, the US, have what they call the CDC. They do surveillance of these, you know, diseases, even in countries that they do not, you know, care about. And so a company like Covance is actually a contract research organization. One way by which you can collaborate is to be involved in clinical trials. You know, if you want later on, you know, I can send you a link in ways by which you can be able to find opportunities by which you can participate. And so we can follow up that one with you later on. From Dr. Sigoro on why COVID-19 is having high effect or quite prevalent in the US compared to Africa. I did give or try to explain using only one factor, age. Age is one big issue. I did say that the many cases of COVID-19 deaths in the US is because of the high, you know, number of people who are aged or who are old compared to Africa. We also have a case of what we call comorbidities. Because of you know, sedentary lifestyles, we do know that the majority of the people in Europe and in the US are obese. You know, they have high blood pressure and all this, and I'm sure the doctors in the room can accept or allude to this, that, you know, these comorbidities also contribute a lot to the severity of COVID-19. Yeah, so we can go on and on why we have differences. I know some people are trying to come up with, many kind of hypotheses why, Africa has not really been affected that much. But then again, if you talk about India, all of a sudden we started seeing, high cases of, COVID-19 in India, and indeed new strains in India. So we cannot really be able to just stamp at this moment and say that we have low cases of COVID-19 in Africa. Who knows what is going to happen? And we wish it doesn't happen. But I think one single factor that that is very evident out there is that age profile of people in Africa is extremely different from those ones in the US. And on medical healthcare, actually it would have been worse if we didn't have those effective medical healthcare systems in America. And lastly, Africa operates what we call open air economies. People go to the markets, it's open air. The shops are wide open. But in Europe and the US, actually, it's a closed, air economies where people are working in a room. You can't even repair your car in the open. No, even cars are repaired inside a building. And so this closed kind of, economies also increase the level of transmission, from one person to the other. Not to mention the question of the weather. The cold temperatures keep people inside, and therefore transmission between one person to the other one is unique to countries where we have very cold temperatures, unlike in Africa, where temperatures are quite, high and accommodative. So to speak, really, the kind of, economies of Africa where people walk to the market, where people don't have motor vehicles, where people, are open, where windows are open, there is less transmission of COVID-19, and there's a lot of evidence to suggest that, and we can go on and on and on.
We had also questions on the floor to Fountain Healthcare.
So thank you. And I want to appreciate my colleague, Dr. Dombera, for very clearly bringing out some of those attributes that we are learning out of this pandemic in regard to why the disease is picking element X and not element Y. So first, on the issue of vaccination and response, and I think Prof had asked, how are we measuring? Of course, at the facility, we have both the qualitative and the quantitative ways of assessing. On the qualitative ways, for example, we are observing the clinical signs and symptoms that we had just enumerated. That when people are admitted at the facility and they are coming and you have made a diagnosis of COVID-19, there are things that initially you could observe like cough. The person, you are just coughing all through. Fevers. We have high unexplained fevers that run 38.5 plus continuously for almost 36 to 48 hours, especially day 4, 5 of infection. So we were able to observe that, and when this patient could come, especially in our setup, there was a lot of confusion with severe malaria cases because the signs and symptoms were very, very similar. To the people who are aged, especially those above 55 years in our setup, and also patients who come to our clinics and they are diabetic, and there are others who are hypertensive. So when you get these patients, most of them will progress to either high dependence unit or the intensive care unit. And now the observation that we made is that for those who have been vaccinated from these particular categories, you could find that the number drastically reduced by almost 50%. That those that we were admitting in ICU and HDU was coming down to almost 50%. And for us, we feel it's an observation worth noting, because if you're able to make that, then more needs to go into it to just understand how these things are working. Prof also asked about data this data that we are generating, is there a way we can collaborate as institutions and we'll be able to keep this particular data? Prof, I'm happy to say yes, because as Fountain Healthcare, we have realized there is this need, and we have formed another group within ourselves as doctors for those who are interested in research. And we have Fountain Projects and Research Office called FOPRO. I will be willing to spend a bit more time with you so that we can talk more about this FOPRO. We are already doing some clinical trials with a few institutions, University of Washington, University of Witwatersrand in South Africa, among others that we are collaborating, with, University of Manchester, and also even the AstraZeneca team. There are some research that is currently ongoing, and there's another one that we are starting in 4 months' time that already has gone through the approval stages, and I think Western region will be one of the regions who will be participating in those trials. So already there is something we are doing that we believe we can collaborate more and harness more of this. And even to Dr. Ndombele on Covans, and you are asking about that partnership with institutions, especially on clinical trials. Already we have indigenous local institutions like Fountain Healthcare that are already in that particular niche, and we believe this can be areas of collaboration in future engagements. Then lastly, my friend asked about the uptake of vaccines, especially amongst the healthcare workers. I will say, when I look at the data in Bungoma, because I'm privileged to be close to the team, the surveillance team, and the team that has been offering this vaccine, and Fountain Healthcare being one of the centers that is offering this vaccine, like at our facility, without coercion, about 94% of the workers in my facility received the vaccine. And the 6% will be like 1 or 2 persons. And despite the fact that they are doctors, nurses, these are people from diverse backgrounds. There are those who come from institutions or religious organizations that don't believe in vaccination. And you see, you cannot force them. They tell you, in my religion, father has said we are not going to be vaccinated. And also, there are also those anti-vaxxers campaigners, and people listen to them a lot. And you cannot do much on such, but our role is to persuade them, because we believe that
Thank you, honorable delegates. Sorry, in the interest of time, breakout sessions beginning at exactly 10:10. So we are not going to take more questions because we are likely to interact with the other sessions. I'm sure Dr. Ndombele gave us the contacts. We can still link up with him. If we have any issues, Dr. Ndombele, you have been following the discussions of the chat. You can still respond to those issues. Let me thank you, everybody, for giving me the opportunity to chair the session. MC.
Thank you, Dr. Betty Nyongesa, for chairing the session. Honorable conference delegates, we are running behind schedule. We're going to take a break of 10 minutes, and we are asking the delegates to log into the theme-specific links at exactly 10:10. We're requesting our conference delegates to log into theme-specific links at 10:10. Others want to thank you, delegates from here in diaspora, for being patient with us. We are aware that some delegates from Germany have logged into theme-specific links. They did that as far as 30 minutes ago. We want to really apologize, but at 10:10, we shall be ready for you. Thank you, and we are signing off this specific session, but we reconnect at 10:10 through the theme-specific links. On behalf of my co-host, Dr. Laura Mamuli, we want to say thank you for staying with us. Thank you.